Hello. Welcome to the Helen Bader Foundation CBRF Caregiver Training Program. This unit is on the management and administration of medications in the CBRF. Because it's such a large unit, it's divided into a number of parts. Each has a video and a workbook. This is Part 7, Responsibilities related to the management and administration of drugs in the CBRF. I'm Marin Meyer. I have an interest in geriatrics, and as a result, I've worked in long-term care for a long period of time. I'll be presenting this unit, and as you know, each of our parts starts with a pretest. The pretest and the post-test are identical. There's no grading involved. The tests are designed to give you an idea of what you already know as you go into the program, and what kind of information we want you to come away with when you've finished it. It by no means covers all the information we want you to know. It's just to give you an idea. Right now, what I'd like for you to do is stop the video, take the pretest, and when you're done, come back. Welcome back. I hope that wasn't too hard. This section covers a lot of the legal aspects of medication management and administration. Under A, we have definitions. I'm not going to read these definitions to you, but I will refer to them. If you have questions about what it means to administer a drug, then go back to the definitions. If you aren't sure what it means for a person to be a nursing supervisor, go to the definitions, and that'll help you. So what we're going to do is we're going to move on to B, training in the management and administration of drugs in the CBRF. Anytime you have questions about the rules or the interpretation of the rules, you or your CBRF owner or administrator or nurse should feel free to contact your licensing specialist. You can refer to your rule and have it in your hand when you call them, but these people are there to help you and to help you understand what it means in the context of your particular setting, because here we can't really deal with the specific questions that each individual CBRF might have. We're going to just give you a general overview of the rule. So, under number 1, all supervised and unsupervised non-medically licensed staff must receive training in medication management. Now, what we mean by non-medically licensed staff, if you refer back to your list under A, that means employees who are not either a practitioner, meaning like a physician, a pharmacist, a registered or licensed nurse in Wisconsin, or a medication aide who's been certified in medication administration. So that covers a lot of people. If you are not medically licensed, you must receive the training before offering any help at all with medication management. So you have to be trained regardless of whether you are supervised or are not supervised if you are not medically licensed. Now, under 2, unsupervised, non-medically licensed staff, if you are not medically licensed and not supervised, then you must meet certain requirements as specified under HFS 83. First of all, you have to complete 8 hours of training that's approved by the department. Then you also need to manage and administer your medications that are packaged by a pharmacist in some kind of unit of use packaging. And the department has offered a lot of latitude here as to what unit of use can mean. It could mean multi-day pill holders, it could mean unit dose, it could mean blister packs. So it's not very restrictive, but it is to keep you from having to deal with bulk packages. If you are supervised and non-medically licensed, then, and that means that you're under the general or direct supervision of a licensed person. Then you make complete training that's offered by the person supervising you, by the licensed person. So that would mean that the RN or pharmacist supervising you could create training, would determine the amount of training that you needed. General or direct supervision, if we go back to A, general supervision means that the pharmacist or RN is regularly available to coordinate and direct and inspect your practices. The direct supervision means that they are immediately available to do those things. So they're right there at first hand to be able to make sure that you are performing the tasks as they've specified in their protocols. Let's go on to C. What does it mean when a resident controls their medications and administration of medications? The intent of living in a CBRF is for an individual to be as independent as they can safely be. And because of that, all prescribed and non-prescription medicines shall remain in the control of the resident for whom they're intended, and they should be self-administered by that resident unless the resident has been found to be incompetent in a court, or if the resident does not have the mental or physical ability to self-administer as determined in writing by the resident's physician, or if the resident has made the choice to defer control of the administration to the CBRF. Now, when we talk about the residents deferring control, there are a lot of instances when people go into CBRFs and they've just had so many problems handling their lives in general that when they're asked, well, did you want us to administer your medicines? They say, by all means, take it away from me, okay? That's really not the intent of living in a CBRF. Sometimes when people first come into the facilities, they may need more help, but once they get situated and start feeling more confident, it's important that they maintain this control even though they may not necessarily want it, okay? So what we have here are some provisions to help you decide whether you are interfering a little too much with someone's independence. A written statement has to be given, signed by the resident, that has the date, the resident's name, and the fact that they want to defer control of their medications to the CBRF. And it has to also specify either the staff person or the staff position to whom they are deferring that responsibility. But it's important to realize that you cannot coerce a resident into deferring to the staff. You can't make it a condition of admission to the facility. Say, well, we only take people if they let us manage their meds. Okay, that's not in the interest of CBRFs. And you also cannot in any way imply that a resident wouldn't be admitted to your facility because they wanted to self-administer. So it's important for you to look at administration in the same light that you look at your own self-administration. If you're like me, your administration is not flawless, but it's pretty good. And it gives you control over your destiny, and that's really the intent here. Now, the CBRF staff may and really should teach residents about self-administration. And they should document this when in the ISP, when they determine or they do an assessment of the resident and find that the resident is capable of administering medications. It's important for them to begin a process of educating the resident about the medications, about the importance of taking them properly, about the side effects. It just depends on the resident, but that's stuff that needs to be put in the ISP. The CBRF staff who are doing the medication teaching should be under the supervision, either direct or general supervision, of an RN or a pharmacist. And like I said, you need to document in your ISP what kind of teaching is being given, when it's being given, what kind of control the resident has over medications, and also it should include an assessment of the particular drugs that the resident is taking. Now, this is a question that comes up a lot, is can I help a resident in any way if they're self-administering their medications? What you can do is specified under C5, and that is the CBRF staff member may break open the drug container for a resident who is unable to break it open, and then the staff member would observe self-administration. Self-administration can be supervised by a staff member who then prompts the resident to administer the medications and observes the fact that the drugs were taken and administered. And when a resident is supervised, then the staff member does need to record on the MAR or the medication record the type of drug that was taken, the dose, the date and time, and any change in condition that was observed in the resident, and any comments that the resident might make regarding his or her health condition. How do we assess a resident's ability to manage and administer medications? First of all, you need to do that immediately upon admission to the CBRF. And as you know, a lot of times when people are coming into the facility, they are not in their optimal condition. So just the fact that someone may or may not be able to administer their own medications at the time of admission doesn't mean that things don't change. And so at least annually, you review a person's ability to self-medicate. And I would suggest that you do that any time that you have a change in condition. For example, once the resident settles into your facility, you may find that their abilities are way greater than you expected. On the other hand, you may find that an individual is deteriorating in their abilities to manage medications, and so a review would be a very good idea then. The assessment should include, at a minimum, a nursing assessment, an assessment of the resident's physical and mental abilities to perform the tasks that are related to medication management. You should get some input from the resident's guardian or representative if there is an individual like that available. You need input from the prescribing physician. And when appropriate, you need an assessment from an occupational therapist. And as I said in another part of this unit, occupational therapists are really quite remarkable in their ability to help people overcome disabilities. So you should have all of those assessments done. Then a summary should be made from those individual assessments, and that should become part of the ISP. Now, when a resident is willing and able to administer their own medications, you need to get a written permission order from the resident's physician that specifies that the physician is aware of this and agrees with that assessment. Then you need to establish a goal, and probably we should all do this personally also, but at least in the CBRF we're required to do it. You need to establish a goal of, first of all, where is the individual now? That you've determined in your assessment. And then you decide where you would like this resident to be going. Some people will only be able to maintain the status that they have now. Some people will be growing in their abilities. And so that would be something that would be documented in the ISP again. It needs to be very specific so that you can provide training that allows the person to become competent. So you want to make it a very realistic goal, and it can be a very small but measurable increment that you plan to train. And then when the individual achieves that and has maintained that level of performance, then you can establish a new goal. The CBRF needs to provide a secure, locked area inside the resident's room where the resident can safely store the medications. Now, residents are not allowed to administer controlled substances, not allowed to self-administer those. The CBRF staff has to do that and has to keep records of those controlled substances. The CBRF staff also assumes the responsibility of administering a form if the resident is unable to administer and record the administration, him or herself. And as I said earlier, the staff can break open the immediate packaging for the resident, but can't take the medication out for the resident who is self-administering. The CBRF staff who is supervising self-administration by prompting has then to do the documentation that we mentioned earlier. And anytime a resident becomes, for example, acutely ill, say they have pneumonia, and you know how you are when you are ill, you just need someone to take care of you. In a case where a resident is ill, it's okay for the staff to assume that responsibility, but it's important always to reassess the resident when they're better and see if you can't return that resident to their original level of functioning. So just because you assume the responsibility once doesn't mean that it never goes back to the resident. It's really, the whole thing is a progression, and the progression is documented both in the ISP and in your progress notes. So it gives you an idea. Medication management in CBRFs is sort of like the 3 steps forward and 1 step back. Sometimes, you know, it'll be 2 steps forward and 1 step back, or 2 steps forward and 2 steps back. But it's always going to be a progression. It's never just set in stone. On the next 3 pages, we have some helpful tools for you. Under H, we're going to talk about what happens when the CBRF staff either controls or assists with medication management in CBRFs. Now, this is different than supervised management, so go back to A and check your definitions. When the CBRF assists or actually administers medications to a resident, again, they need to do the documentation, and that documentation would include what drug was administered, the dose, the date and time it was given, any changes in condition, and any concerns or comments that the resident had about their medical condition. I, residents' rights regarding medications and drugs. Residents have a right to privacy. They should be offered the right to receive their medications in a private setting. And this, again, is something that they may change their minds about. They may be in your facility for 6 months and be receiving their medications at the dinner table with no problem, and suddenly they may change their mind, and that is their right. They have the right to confidentiality, which means that staff will only communicate about a resident's condition and medications when it is appropriate to talk about that, not just for idle chat, but because there is a specific health care issue involved in transmitting the information from one person to another. The resident has a right to receive all of their prescribed medications in the dose and at the time that they were prescribed by the resident's physician. They have a right to be free of excessive medications. They have a right to be free of medications that are used as punishment or as restraints. They can't be given drugs to substitute for receiving therapy, okay? And they can't be given medications that are going to interfere with their therapies. Any competent resident can refuse medications. There are rules that specify exactly how you handle that situation. When a resident refuses medications, it's important that the staff member discuss it with the resident, offer a number of alternative times, for example, or settings. Maybe the resident would like to receive their medication in their room or after dinner or something. But it's important that you document each of those approaches and that you offer the resident enough alternatives that they can exercise some control over the process. You need to document both your refusals, the resident's refusals, and your attempts to administer medications. And refusal to take a regular medication for 2 consecutive days is something that needs to be reported to the physician. Now, there are some medications that shouldn't even be missed for a day, and your pharmacist and licensed person should help you determine which medications those are. For example, somebody who is on a maintenance dose of prednisone shouldn't even miss a single day. That's something that would be noted both in the ISP, the progress notes, and probably on the MAR, so the individuals who pass medications can be aware of that. Residents also have a right to be free from medications that are forcibly administered unless there is a court order to do so. Now, another thing that has come up in discussions with CBRF employees is the choice of providers. Residents have a right to choose their health care providers. That includes their physician, their podiatrist, their dentist, their pharmacy. Okay? They can't be forced to use a particular pharmacy, and no policy can be written by the CBRF that forces residents to use a particular pharmacy. As mentioned earlier in this unit, residents have a right to be free of both seclusion and restraints, both chemical and physical restraints. And read through this section again. You cannot provide a PRN psychotropic medication to a resident who has no scheduled psychotropic medications. A resident who is on a scheduled psychotropic medication may have a PRN psychotropic that is either the same or a different psychotropic medication, but you need to review that information from that particular unit, or read through the rule and read through this part of the workbook. It's very important that you're really clear on this because you don't want to violate your residents' rights. When a psychotropic drug is being given, the resident needs to be assessed on it routinely because you're going to be measuring behaviors, specific behaviors, and then also you'll be doing at least a quarterly review of the medication. Is the medication working? Does the resident seem to have some kind of side effects from it? If there are side effects, what has been considered about those? Can the dosage be changed, or should the medication be changed? So that would all be part of the quarterly assessment. And the quarterly assessment needs to be documented in the patient's or the resident's permanent record. And we've got an example of psychotropic drug monitoring sheet again here under J, and this is something that you've seen before. It's a review, and as I said, it never hurts to review. The more times you review information, the more likely you are to see things that you could customize for yourself, or maybe to pick up something that you may have missed in another sitting. Under K, we have a listing of psychotropic medications. And I would post this somewhere or else have a book. I actually have a file called Stuff I Always Need to Look Up. It's pretty sophisticated. This would go into my Stuff I Always Need to Look Up file. And that way, everybody would know where it was. Under L, we have a miscellaneous assortment of rules in HFS 83 that pertain to medications. First of all, any drug or medication in your facility needs to be labeled by a pharmacist. Secondly, any medications that are packaged by a pharmacist need to remain in the packaging until the medication is being administered to the resident. If you, for example, take a medication out of a package for a resident and the resident absolutely categorically refuses to take it, you cannot return that medication to the container. It has to be destroyed. And there is a process for destruction and recording the destruction of medications, which we'll go into later. If one or more physician sees your resident, and it's not your resident's regular physician, a list of all the drugs your resident is taking needs to be provided to that other physician or dentist or nurse practitioner or podiatrist. Everybody who prescribes for your residents needs to have that medication information. That's one of the checks in our healthcare system that keeps residents from receiving medications that are harmful to them or that interact with the medications they're already taking. So, except in an extreme emergency, there would be no instance in which your resident would not be accompanied by a list of their current medications. When a resident requires a registered nurse or pharmacist is a special case that the department may determine. If things are going very poorly for your resident or if things are not going well for your facility, the department may determine that your resident or residents need more direct contact with a nurse or a pharmacist. If a resident is going to be absent from the CBRF, the resident's pharmacist or the CBRF staff under general supervision from the pharmacist or a registered nurse can prepare the medications that will be taken along on the leave of absence. Keep in mind that this is an opportunity for error and that it's important that every medication be labeled with the name of the medication because, for example, say my mom is in a CBRF and I'm bringing her home to my house. Well, I have a grandbaby and mom is there and the grandbaby is there and there is a potential for poisoning with either one of the two of them. If that were to occur, I would need to have the names of those medications available to me right away without having to call the CBRF again. So it's important to label the medications with the names and what they're for and when they're to be taken. Now, what is the pharmacy? What is their role here? Every CBRF needs to have a policy, a written policy, that tells exactly what the staff person who is responsible for ordering, receiving, and reordering medications does and how they do it. It's important that you know who is responsible for each of those tasks. The CBRF needs to arrange with a pharmacist or a physician to review each resident's administration record and their entire regimen at least annually. First of all, the initial review by a physician or pharmacist has to be done within 30 days of admission, and then at least annually, and when the resident's condition significantly changes. For example, if you have a hospitalization and the medications are significantly changed, then either the physician or a pharmacist needs to review those medications. That needs to be documented in writing by the person doing the reviewing, and one of the reports needs to be sent to the administrator to be included in the resident's chart, and the other copy should go to, well, 3 copies. One should go to the reviewer, one to the administrator for the resident's chart, and one to the prescribing physician. All medications need to have a physician's order. This makes sense. I mean, especially prescription medications. There's a prescription order someplace. One of those copies of that prescription order need to be in the CBRF. And when the medication arrives in the facility, a pharmacy label has to be permanently attached to the medications. It should have the name of the resident, the name of the drug, the dosage, the medication, the directions for use, who prescribed the medication, and the name and phone number of the pharmacy. And those are all things that are required by the pharmacy examining board. So there's really no way to adjust that. You just need to make sure that that's how it shows up at your facility. Non-prescription drugs also need to be properly labeled. If a resident is taking things according to the labeling on the package, then it would be adequate to add the resident's name and make sure that there's an expiration date. What has to be on every non-prescription drug is the resident's name, the name of the drug, the directions for use, and the expiration date. If the resident is taking the drug in a way that's not specified on the packaging for non-prescription use, then that would become a prescription item. Anytime you use a non-prescription drug in doses or in ways that are not consistent with the labeling, then a physician should make an order for that. Anytime that you have a label that's not clear, always check with the pharmacy. If the staff member is not supervised by an RN or a pharmacist in the management and administration of drugs, the medication has to be packaged in some kind of unit of use packaging. And this was shown earlier in part 2 of this section. Any change in physician's orders for a prescription or non-prescription drug needs to be promptly communicated both to the pharmacy and to the CBRF staff. If a prescription direction changes, you'll need to get a new label for your medication. Otherwise, your medication won't accurately reflect what's on your MAR, and that will eliminate one of your safety checks. So you need to be sure to request a new label from the pharmacy on that. There are specific rules that deal with the disposal and receipt of medications at CBRFs. And on the next page, we have a couple of samples for you there. You don't have to use these particular templates, but it's an example of the information that is required. You must keep a record of all the medication that comes into your facility. And when medication is destroyed, you need to have a record of that. Under P, we have some information about drug packaging. Most pharmacies use the traditional packaging method of putting, say, a month's supply of medications in a pill vial and affixing the label to the vial. Some pharmacies that routinely service nursing homes or CBRFs or assisted living facilities may be dispensing medications in some other form, for example, unit of use packaging. Remember that any non-medically licensed person who is not being supervised by a nurse or pharmacist has to administer medications that are in unit of use packaging. And that is listed here. That can include unit dose, unit time packets, blister packs, multi-day pill holders, or any similar device that safeguards both the resident and the staff member. So what we're going to do is discuss 2 forms that are most commonly used in CBRF settings. Basically, there's the single dose approach. That means that each dose of medication is individually packaged and labeled by the pharmacist, and it has the amount of medication in it that's required for 1 dose. Each dose would have the name of the medication, its strength, the expiration date, and often a lot number, and sometimes it'll have the resident's name on it. The single dose packaging is one of the safest and most convenient ways to receive medications and also to administer them. It requires very little handling, and the individual wrapping provides a real clean way of handling the medications. Some examples of single dose packaging include the unit dose, where these little pods have a single dose included in them, and maybe they appear in a separate drawer for each time period, or say all of the digoxin unit of use pills might be in one section. Another example of single dose packaging is the blister pack. It's a little raised bubble, and it can contain either a single dose or it may have a strip of single doses for an entire week. Some companies even make single doses for an entire month. So it depends on the blister system that the particular pharmacy uses. Let's talk now about multi-dose packaging. That's really the traditional packaging where you have multiple doses that are in one container. The drugs are packaged and labeled by the pharmacist. Each of these containers has to have the resident's name, the name of the medication, the strength of the medication, and it has to also include the pharmacy name and phone number and address. We need to know who it is that is going to be administering the medications. That's something that has been determined in writing by the physician. So when you're using traditional packaging, that administering person is going to pour out or measure a single dose from the bulk bottle. And because these bulk or multi-dose bottles require more handling, there is sometimes more of a chance for error, and there's certainly more of a chance for contamination. Now, when medications that have been traditionally packaged are discontinued or the dosage is changed, all of the unused medication in the container has to be destroyed, and you need to use your disposal form for that. Some examples of multi-dose packaging include the bottles that we've just mentioned, and that's where you take each dose out at the appropriate time. Blister pack is a card that has a blister pack container in it, and each blister pack may have, say, any number of pills in it. Say in the morning an individual receives 5 pills. All 5 would be in one of the blister packs. So one of the disadvantages of that kind of packaging is if one medication is discontinued, the need is to dispose of all of the rest of the medications. There are also unit time packets, which are generally some kind of small sealed container, like small sealed plastic bags. And they would have all of the doses for a particular time period in a bag. There are also multi-day pill holders, and they have individual compartments in them. Each individual compartment usually either has a single dose or it may have all of the doses for a particular time of day. So you can see there are a lot of different ways to approach this. With the multi-day pill holder, the compartments are filled from the bottles by either an RN or an LPN under the supervision of an RN. And this is something that requires a lot of concentration, because when filling these multi-day holders, there is the potential to make an error and have that error be duplicated in each of the holders. So it's important not to interrupt someone who's doing that particular task, to let them concentrate entirely on what their job is at that time. If a CBRF is going to use multi-day pill holders, they need to have a written order from the physician that states exactly what method they're planning on using, the name of the resident that they'll be using it on, which medications will be administered that way, and the specific names or the role, the staff role, who will be providing those medications from the multi-day pill holder. Under Q, let's talk about medication storage. The location in which you, in your CBRF, store your medications is going to vary depending on the kind and size of facility that you have. Now, we're going to discuss the specific regulations that every CBRF has to adhere to. First of all medications and drugs have to be stored in their original containers and not transferred to any other container except by a pharmacist, a prescribing physician, or the appropriately licensed person. Most medications can safely be stored at controlled room temperature. That means they should be protected from heat and from light and from moisture. Now, drugs can lose their potency if they're exposed to moisture. They can lose it if they're exposed to sunlight, for example, nitroglycerin. Another example is the EpiPen, which has epinephrine in it, which if exposed to heat or light degrades and then becomes useless. You should never mix medications in one container. I have people sometimes come to the pharmacy and they say, well, I'm out of town and I brought my pills with me and I'm going to be one short. And I say, well, if it's in the container, that's fine. And maybe the pill container says hydrochlorothiazide, but there are 4 different color pills in there, so you know something is wrong. They've mixed things into one container. That's a very unsafe thing for anybody to do. And certainly don't do it in a CBRF. Also, never remove a label that a pharmacist has affixed to a bottle. And we want to get away from the idea that the bathroom cabinet is a medicine cabinet. Because of indoor plumbing, bathrooms have a tendency to get either very hot and humid or cool down and be humid. So don't store medications in bathrooms. The cabinets that we do want you to store your drugs in need to be large enough to accommodate all of the drugs for all of your residents without crowding. Okay, it's very important to have an adequate amount of space so you can keep things organized. And you want to keep that area clean, tidy, and just be really rigid about how organized it is. That way you won't make mistakes for some silly reason. The medicine cabinets or rooms have to be kept locked, and the lock can only be available to staff who are authorized to have the key. So always keep that door locked. You open the cabinet, you take out what's needed, and you lock the door again. You don't leave it locked. You don't leave it unlocked while you go and administer meds, for example. The key also either needs to be on your person or on the person of another staff member who is authorized to have it, or it's got to be kept in a safe place. It can't just be available to other residents or to people who come in to visit your residence. So be sure that those medications are safely stored. That is your legal responsibility, and you certainly, if medications were missing, you wouldn't want to be put in a position where you have to admit that you had laid the key down somewhere. Some medications require refrigeration, and if they're stored in a common refrigerator, which they often are, for example with the butter, cheese, and milk, they have to be kept in a locked container and properly labeled. And those medications that are labeled with a sticker that says keep refrigerated belong in the regular part of the refrigerator. If it doesn't say keep refrigerated and you think it should be, call the pharmacy and verify, or look it up in one of your drug references, which I hope you're using a lot. If you put medications that shouldn't be refrigerated in the refrigerator, it may also cause a stability or a strength problem with the medications, and so the medications might need to be disposed of. So you don't want to waste those. Non-prescription medicines and prescription medicines should never be stored near household chemicals. There is just an enormous potential for error there. A lot of the bottles look similar. Now a lot of the chemical bottles have the double safety locks on them, which would advise you at least that you were opening the wrong thing. But all medications have to be kept separately from household cleaners and other contaminants. So store them completely away from each other. Also, in the CBRF and in most other long-term care type facilities, internal medications have to be stored separately from external medications. So you could have an individual's medications for internal use and then have another section in your medication cabinet that has their external preparations. And an example of external preparations would be lotions or creams or medicated shampoos, eye drops, vaginal suppositories, that sort of thing. There are a lot of plastic containers that you can buy in hardware stores or in variety stores that can help you organize your med cabinets. They're pretty inexpensive. You can make it colorful. And it wouldn't hurt to have a different color for internals versus externals. So in the event that a resident is handling their own medications, if they're managing and administering their own medications, they need a secure area in their room. That could either be one of those small locked boxes, or it may be a locked drawer in a dresser drawer, for example. Let's talk about drug disposal now under R. A resident's prescription medications that are not to be used any longer need to be destroyed within 72 hours of discontinuation. Now, there are a number of reasons that a medication might be discontinued. It might not have been effective, or the resident might have had an adverse effect to it. They may have been discharged, they may have died, or the drug may have become contaminated or lost its potency. Or, for example, you removed the medication from the package and then the resident refused, or there was some other reason that the resident decided not to take the medication. In that case, it has to be destroyed. In order to destroy it, you need to complete the paperwork. You have to account for every pill that both comes into and leaves your facility. So it can come in and it can leave your facility by means of going into a resident, at which point you document that, or it can come into your facility and leave your facility by means of being destroyed, at which point you document that. So you should be able to account for every single dose that comes and goes. You need to keep those records. The Pharmacy Examining Board now states that medications should not be returned to the pharmacy for destruction. So you need to be destroying those yourself. Your form for disposal of medications needs to be witnessed and signed. It has to be signed by at least 2 people, and those should either be an administrator or the administrator's designee, a registered nurse, a pharmacist, or another employee. Now, it's a good idea when any medication gets discontinued for you to check through all the medications. The things that I find that are most often outdated are going to be things like eye drops, inhalers, oral inhalers, and topical preparations, because people don't really seem to think of those as things that go out of date. But anytime you're going to be cleaning out your medicine cabinet for some other reason, just check everything. It doesn't take a lot of time, and it protects your residents from unsafe or expired medications. You also want to be sure you check all the scheduled medications and the PRN medications. And if residents have medications in their rooms, you might want to ask them if you can check that for them or remind them to check their own expiration dates. And one suggestion is to mark a particular date on the calendar so that every month you check that. Now, when I go into a nursing home, that's part of my monthly check. But since you probably won't have a pharmacist coming in on a monthly basis, then you'll need to perform that task. Under T, let's talk about controlled substances, both their storage and disposal. As we discussed earlier in this unit, there are 5 schedules of controlled substances, and we've included the schedules and some of the drugs in each schedule just as a review for you. And as you recall, those are drugs that have a particularly high risk for either abuse or diversion or for addiction, or are just especially dangerous. Controlled substances in the Category 2 schedule have to be separately locked inside another locked container. So it's a double locked system. And when you have Schedule 2 drugs like pain medications like Percocet or Demerol or Ritalin for attention deficit disorder, those things you need to keep a separate record of that includes the resident's name, the prescribing physician's name, the dosage of the medication, the time and date administered, the signature, not just the initials, but the actual signature of the person who administered the dose, and the remaining balance of the drug that you have in the facility. Every day, and that means every 24-hour day, you have to take and audit all of your Controlled 2 drugs. And you can either do that on a separate sheet or you can do it on the same sheet. And I would just call that 24-hour audit and then show that the count was correct. but you would need to make the count, and then you would sign that. So under number 4, look this over carefully and make sure that you keep up with those records. And because the controlled substances audit has to be done every 24 hours, put it someplace that you're going to see it. For example, you could put it on a clipboard right inside the medication cabinet, or put it someplace where the administrator will be looking every single day, because it is critical to have that done every 24 hours. Under U, we have a sample controlled substances documentation sheet. Again, you don't need to use our form, but it gives you an example of all of the information that needs to be included. And be sure you include the amount of medication that's left, and be sure that either on that sheet or on another sheet you have the 24-hour audit. Now, we've covered the responsibilities that are described in HFS 83 that relate to the management and administration of medications in the CBRF. So we're going to wrap up Part 7 with our post-test. Remember that the post-test and the pre-test have identical questions, and you won't be graded on them, but we will review the responses when you finish the post-test. So right now I'd like for you to stop your video, complete the post-test, and then come back. Welcome back, and I hope you did considerably better on the post-test than on the pre-test. Under Part 7, responsibilities related to the management and administration of medications in the CBRF, I'll read the question and then I will tell you which letter corresponds to the correct answer. Number 1, unsupervised, non-medically licensed staff means A, staff that is not supervised by a registered nurse or a pharmacist in the management and administration of meds, and who are not practitioners, pharmacists, registered nurses, or licensed practical nurses. 2, supervised non-medically licensed staff means B, staff that is under the general or direct supervision of a registered nurse or a pharmacist in the management and administration of meds, and who are not practitioners, pharmacists, registered nurses, or licensed practical nurses. 3, all drugs shall, D, all of the above, be labeled by a pharmacist, remain in the package until given to the resident, and have a physician's order. 4, a resident has the right to D, all of the above, receive medications in privacy, choose his or her own pharmacy, and be free from drugs and medications used as punishment for convenience of the staff. 5, when a resident controls his or her own drug administration, the answer is C. Self-administration of drugs may be supervised by staff who prompt the resident to self-administer the meds and observes the fact of administration and the dose taken. Number 6, when the CBRF staff controls the resident's drug administration, A, a written order must be obtained to do so from the resident's physician. Number 7, the pharmacist, D, all of the above, will package the meds in unit dose if the staff members are unsupervised, shall clarify any unclear drug labels, and will label all drugs or meds. Number 8, drugs must be packaged and labeled by a pharmacist in unit dose, unit time packets, blister packs, or multi-day pill holders or similar devices if B, if the staff is non-medically licensed and not supervised by a registered nurse or pharmacist. 9, A med is discontinued by the physician. The medication is not a controlled substance and is not returned to the pharmacy, therefore shall be destroyed within, the answer is C, 72 hours of the physician discontinuing it. Number 10, controlled substances are C, separately locked in securely fastened boxes, drawers, or permanently fixed compartments within the locked drug area. This concludes part 7 of the Medication Management and Administration in the CBRF unit. Thank you, and I hope the information has been helpful to you.